All right, cranial nerve lesions. Okay, just recall the rule of four. So there are four cranial nuclei above the pons. There are four in the pons, and there are four in the medullas, and they all run chronologically. Also, rule of four, if you are divisible by 12, in other words, 3, 4, 6, and 12, not 1 and 2, because technically they're above the brainstem. 3, 4, 6, and 12 are all midline for the brainstem. We're going to go into this way more depth, but 1 is smell, 2 is afferent visual, 3, 4, and 6 are motor. Trigeminal, we have V1, V2, V3 for sensory of the face. V3 also does muscles of mastication. V7 is mostly going to be facial motor. V8 is sound and hearing. That's vestibulocochlear nerve. 9 is going to be gag reflex, swallowing, the back of the tongue, and the carotid sinus reflex. 10 is going to be the aortic baroreceptors in addition to parasympathetic nervous system, also a little bit of swallowing, the gag reflex. 11 is shrugging your shoulders, turning your head. 12 is going to be sticking out your tongue. All right, so 1, olfactory trauma to the face can damage the cribriform plate where the olfactory nerve is, and you can't smell. Cranial nerve 2, so it's highly myelinated, so MS is going to affect this. An optic glioma can affect this. This is associated with neurofibromatosis type 1. And a pituitary adenoma can, or I guess an anterior communicating saccular aneurysm hemorrhage can cause bitemporal hemianopsia, which is arguably part of the optic nerve. And we mentioned that right there. So yeah, you wouldn't be able to see, or at the very least, it depends how damaged it is. You might lose, a relative afferent pupillary defect. So your pupillary light reflex either completely goes or it goes a little bit. And this is what bitemporal hemianopsia looks like, which we'll talk more about later. I guess soon. So just to recap. So actually, just recall that the left visual field. Actually, I like this picture more. So, all right, we're going to do this on the next one. We'll look at this here. So, things are going to cross at the optic chiasm. So, at the end of the day, everything after the optic chiasm on the right side, everything on the right side after the optic chiasm is associating with everything you see on the left part of your body. And then everything you see on the left side has to do with the right side of right part of your body. So, everything's kind of flipped after the optic chiasm. Even up, down. So we have these dorsal tracts which move up, and they are going to account for the lower visual field. And then the lower visual field, Meyer's loop in the temporal region, is going to be associated with the upper visual field. We're going to see more of this right here. So this is going to be temporal vision. This is nasal vision. And just think about the way that a photon would move, right? A photon is going to move straight in a line like this. It's not going to curve off and go over there. It's going to go straight like this. So it should make sense that the temporal goes over here and then the nasal goes over there. And then similarly here, the nasal is going to go right there and then the temporal is going to go right there. So that's number 1. Definitely get that down. And again, after the optic chiasm, everything I see on the right side has to do with everything that I'm seeing over here. And then everything on the left side is everything that I'm seeing over here on the right side of my visual field. So if you get that, it should make everything go a little bit smoother. So macular degeneration has nothing to do with this picture. Just there's, if you have proliferative diabetic retinopathy, or age-related macular degeneration, you'll have a scotoma, you will lose the center of your vision. All right, now let's go ahead and look at this thing. If I damage right here, I'm taking out the whole optic nerve, I have total blindness in one of my eyes. If I have a pituitary adenoma or cavernous sinus thrombosis or anterior communicating saccular hemorrhage, I am going to have bitemporal hemianopsia. It's quite common. Prolactinovas are quite common. If you damage just a tiny little portion right here, okay, if we track this portion here is on the lateral side of our retina. Remember, the lateral side of our retina is receiving input from the nasal field right there. So this would be an ipsilateral nasal hemianopsia. Now, if we damage the whole optic tract, remember, everything after the optic chiasm, everything on the right side over here has to do with the left visual field. So D, we're seeing that we're losing the left visual field and the left visual field. I just can't see anything on the left side of my body. E, we said that it's kind of flipped, right? The dorsal is going to do the lower part of your body, and this is going to be the parietal lobe. And then Meyer's loop is going to be the lower one that goes to the temporal lobe, but again, it's flipped. So that's going to be the upper part of your vision. So this and this respectively, just a quarter, because we're just dealing with one of the tracks at a time. A PCA stroke or an MCA stroke, the macula is very important, that part of the region that's processed in the occipital lobe, so it gets a dual blood supply. It's not like a watershed infarct. It is like super well supplied by both sides. So if one side goes, then the other side can compensate. So you would lose, if you have damage over here. Again, the right side of the right occipital lobe is going to deal with the left side of the vision. So I'm going to lose all of my left vision, except for the center, because again, we have this macular sparring because of the dual blood supply. All right, we should know all of this. Most everything is just going to be cranial nerve 3. Medial rectus, inferior oblique. Inferior oblique does exactly the opposite of what it says. Inferior oblique pulls up. But unlike the superior rectus, it pulls up and medially. And the superior oblique by cranial nerve 4 is doing the opposite of what it sounds like. It's superior, but it's pulling it down. It's pulling it down, and it's also pulling it in. More oculomotor, we have the inferior rectus, and then we have the superior rectus. So pretty much everything except SO4, and then the abducens, which is 6. All right, so cranial nerve 3 can get damaged. It's really important. It innervates a bunch of different things. It can also be damaged a bunch of different ways. If you have a mass effect or tumor or hemorrhage, uncal herniation can push right into it right there. And remember that there's the parasympathetic fibers from the Edinger-Westphal nucleus for pupillary constriction that lie on the periphery of it. So most of these things are actually going to damage the PNS before they damage the cranial nerve 3. It's usually actually going to get both of them, but theoretically the PNS would be the first to go. So same goes for a PCOM aneurysm, which would damage this if I have a little, barisaccular aneurysm that blows up. The cranial nerve 3 goes to the cavernous sinus. So if there's a thrombosis, that's also going to compress again on the outside first. But again, usually we'll get both of them. So it's usually going to be a bundle. What might be kind of the exception is that if you had ischemia, because it's on the periphery and the blood vessels are right here, they're going to supply the PNS first. And so if there's a shortage, the PNS is going to be fine, but it'll be the cranial nerve that gets screwed up. So if you have a down and out pupil, which would be cranial nerve 3, and you have a normal pupil, then it's likely due to ischemia. If you have mydriasis, which is going to be so the miosis is small pupil, mydriasis is a large pupil. Large pupil is going to be any of these other things, which is probably more common. So down and out pupil or down and out eye with a large pupil tells me that it's any of these 3. And that's called a blown pupil. You also get ptosis because we supply the levator palpebrae, which is going to be like retracting the eyelid, pulling it back from the cranial nerve. And if we don't have that, then it just kind of falls down a little bit. So I think of SO4 for cranial nerve 4 and the superior oblique. Remember, superior oblique pulls down and in. And this could be a medial midbrain aneurysm. It also goes to the cavernous sinus, so thrombosis there would affect it. Down and in, when you're looking down and in, well, if I'm looking at my iPad right now, or if I'm reading a book, if I'm walking down the stairs, and so people might tilt their head to the opposite side to accommodate so that it's actually kind of looking where we want it to look. Abducens is going to abduct, is going to pull laterally. This is also going to be medial pons, also cavernous sinus thrombosis, can't look laterally, and it might even look in a little bit if you're just looking straight ahead. So notice we skipped over 5 because I'm doing all of the motor innervation to the eyes first. So let's go ahead and take a look at this. We're only talking about the right eye, so only look at the right eye. Like in other words, don't look at this side, don't look at this side, don't look at this side, don't look, and don't look. Let's just look at the right eye. Okay, so this is a cranial nerve 3. So I should have, let's just look at the primary position. It's down and out because I don't have a medial rectus to pull it inwards, and I don't have a superior oblique to pull it upwards, and so it's going to go down and out. What about if I want to look to the right? Well, that's actually fine because I can, the lateral rectus is fine. But again, notice we always have this ptosis going on, so we can really immediately tell. What if I want to look to the left? Well, now I don't have a medial rectus. I can't look to the left. All right, cranial nerve 4. So this is going to go, normally it's going to help your eye pull down and in. the superior oblique. And if you can't pull down and in, it's kind of going to go up and out a little bit. So you can kind of tell that there. You can look laterally fine. That's the oculomotor, so that does not really affect it. But here, if I say, hey, can you look in? We have a hard time looking in, or at least in and down, because we don't have this superior oblique. So the oculomotor nerves, inferior oblique is going to pull it up and in. That's the only way you can get this eye to look medially. Okay, what if we have an abducens of I6? So abducens, even when we're midline, notice that it's a little bit on the medial side because, the abducens nerve and the abducens nerve going to the lateral rectus. It's not like the lateral rectus only works when I'm looking to the side. That's when it's working more, but it's always working a little bit just to kind of maintain a homeostasis. So if I have that taken out, it's going to be a little bit of an inward deviation. That's what we see here. What if I say, hey, can you look to the right? Well, then it's really apparent. I can't look to the right at all with that eye. It's just staying straight ahead. And if I say, hey, can you look medially? Then yeah, medial should be fine. All right, trigeminal. So trigeminal is going to be mostly face. So also going through the cavernous sinus. Tumor, brainstem, vascular. I guess you could say that for any of these. You can't feel your face. You get trigeminal neuralgia if someone's brushing their teeth or shaving and somehow it just causes this really severe, intense, brief headache that might be arrhythmic, right? It might come and go and come and go and come and go, and it's apparently quite awful. Back to the nerve though, and what happens if we have a lesion. Sensory issues to the face, but it's also sensory to the anterior 2/3 of the tongue. What do we mean sensory? We mean, this porridge is too hot, right? Not it's tasty, not it's not tasty, it's too hot. Also, V3, the mandibular nerve is for muscles of mastication. And so your jaw actually might deviate to the side where you have the infection or lesion or whatnot. Most of these things are going to deviate towards the side of the lesion. We'll see a few where they go to the opposite side. Usually it's going towards, so when in doubt, that would be a good guess. So we're now, we're still in the pons, but you notice that 4 and 3 we're going to be medial because they're divisible by 12. This is not divisible by 12, so it's going to be a lateral. And a lateral stroke here would be the AICA. You could also have Lyme disease, also a parotid tumor. The facial nerve innervates all of the, most of the glands of the face, except the parotid tumor, which is weird because it goes through the parotid tumor. But that's why it goes right through the parotid tumor to get to the face. And so if you have a tumor there, that could damage it. HSV is known as Ramsay-Hunt syndrome. I think that's what Justin Bieber has. I don't really know. You're going to have facial paralysis. The orbicularis oculi isn't working, so you can't close your eye. It's kind of, sort of, not exactly the opposite ptosis. That's more the Collier sign, but you're going to have this extra wide eye. You're going to have drooping of the face, and it's going to be like you had Botox in your forehead. It's going to be quite smooth. Taste. This porridge is delicious, and it's very sugary, and I love it, to the anterior 2/3 of the tongue. Remember that a lot of the glands, I think it's the chorda tympani or something, is some branch of the facial gland. Facial nerve is a lot of the salivation and taste. Also hyperacusis. So the stapedius muscle, which is going to help the stapes of the ossicles in your middle ear, needs to be regulated by this muscle, and this muscle is innervated by the facial nerve. And so if you don't have it, things might sound super loud. All right, Bell's palsy is going to be cranial nerve 7 palsy. Not to be confused and highly tested, the difference between this and a stroke, a frontal stroke of the MCA. Remember, the MCA is going to be arms, but also face. And so an MCA stroke is going to have a lot of same symptoms as a cranial nerve 7. The main difference, the way you differentiate it, is the facial palsy, Bell's palsy, cranial nerve 7, the forehead has had Botox. And here the forehead is fine. Both these foreheads look the same. So the forehead is actually spared if you have a stroke. Why? For whatever weird reason, you're going to have dual innervation for your facial muscles from both sides of the body, only for the forehead muscles, like the temporalis. So in other words, like, let's say this is my orbicularis oculi, and this is my... I don't know, all the muscles going to my mouth and stuff. So if I have a stroke over here, this isn't working, that's not working, none of that's working. So none of this stuff is working, so we get all of this drooping, and the eye might be a little bit more open. But the temporalis, which goes to the forehead over here, it gets a supply from that. Well, that doesn't work, but it's also getting a supply from here. We have this dual supply. So my forehead, I can still wrinkle it. I can still move these muscles, so it's not going to seem relaxed and smooth. Because remember, Botox is just doing paralysis, so it's kind of mimicking. But if I have a cranial nerve 7 lesion, it doesn't matter where my innervation is coming from in terms of the left or the right brain. I just can't get the message through no matter what. So you will have paralysis here and you will have paralysis here. Vestibulocochlear. Vestibulo is a balance. Cochlear is going to be for hearing. So we are going to have vertigo, the balance, and then tinnitus, so like ringing in your ear and maybe a little bit of deafness. How do you get this? So the cranial nerve 8 is a little bit tricky because it's kind of actually in the border between the pons and the medulla. It will be lateral, right, because it's not divisible by 12. So it could be the AICA or the PICA, which is Wallenberg syndrome. So, I mean, it could also just be tumor. You get smacked in the ear. It could be an infection. It could be a schwannoma, which is associated with neurofibromatosis type 2. We'll get into this, I think, at the end of the lecture. We talk a lot about different ways you can have. This would be sensory neural hearing loss, but also vertigo from the vestibular portion of the nerve. Glossopharyngeal, tongue, pharyngeal, pharynx. It's going to the posterior 1/3 of your tongue. It does sense, so like temperature and taste. It also goes to the pharynx, so it's important for swallowing, so you'd have dysphagia, no gag reflex. Remember, the reflex is usually the smaller numbers for the sensory and then the higher numbers for the efferent, the motor component. So cranial nerve 9 is the sensory, and then in the vagus, cranial nerve 10 is for the motor. The parotid, we said the facial nerve goes through it, but it doesn't supply it. It's the glossopharyngeal which does supply it, so you won't have parotid gland functioning. Also, it's going to regulate the baroreceptors and chemoreceptors of the carotid sinus, so this could affect your heart rate and your blood pressure and whatnot. If you have a lateral medullary stroke, which is actually quite common, the PICA, this is a Wallenberg stroke. Vagus nerve is also going to be a lot of swallowing and your gag reflex. It's actually really similar to the 9 in a bunch of ways. Instead of the carotid sinus, it's the aortic arch receptors that this is interacting with. Remember that the recurrent laryngeal nerve is going to tuck under the aortic arch and go back to supply the voice box. And so if you have damage to the vagus, you're going to have damage of the RLN, and so you're going to be hoarseness. This is a dead giveaway if you see this. All right, so remember, most things go towards the affected side. So it's also important for elevating the palate. So if I have a right palate that is not elevating, it's down a little bit. So actually, let's look at this here. That palate is not elevating, right? This palate is elevating. This one is not elevating. So I know here that the vagus nerve on this side is the one that's affected. Notice that the uvula goes over to the other side right here. It's going across. So that is one of our few unaffecteds. This is also in the same region for the medulla, and it's the lateral because it's not divisible by 12. So this is medullary. I think of medullary, 2 L's, and Wallenberg is going together. Here we have a picture of this palate and the uvula deviation. Also really important for supplying the parasympathetic innervation of the GI system. The accessory nerve, this comes up from the cervical plexus through the foramen magnum, and then it is going to go down through I think the jugular or something, but in any case, if you damage the cervical plexus, this is going to damage the accessory nerve. The sternocleidomastoid, the SCM, is important for turning your head to the opposite side. So this is another one of our opposites, turning the head to the opposite side. the SCM is on the same side, but it turns to the other side. And then the trapezius. So I guess if we're looking at this right here, the trapezius for shrugging your shoulders is going to be damaged. So your shoulder is going to drop on this side. Notice how this is lower than this. And it's also going to cause a winged scapula. So the trapezius, winged scapula, and the shoulder is going to be lower. And the SCM damage can turn your head to the opposite side. Glossopharyngeal. No, this is not. This is the hypoglossus. Nice try. Hypoglossus, hypo under, glossus tongue, under the tongue. And that's where it innervates, but it's actually important for motor innervation of the tongue. So it pushes the tongue out. And if you can't push out, so if here we have a left cranial nerve 12 lesion, well, these muscles are going to waste away because they're not being innervated. They can't be used. They're just going to atrophy. So you can see that muscle wasting right there. But we're going to deviate, like many things, towards the side of the lesion. People say lick your wounds for this because the lesion is on this side and it's kind of like trying to lick its wounds is the idea. This is in the medulla. This actually, I think, would be a medial medullary stroke. So I don't think that's lateral, but an anterior spinal, I guess you could get an anterior spinal injury. So that would be the issue here. But it could as easily be something like a tumor or just trauma.